Everyone, and welcome to the Asthma Care Coverage Project, a comprehensive look into nationwide Medicaid coverage and barriers of guidelines-based asthma care. Later, you will have the opportunity to ask questions during a question and answer session. To submit a question, please use the Q&A box located on the right side of your screen. I will be standing by should you need any assistance. It is now my pleasure to turn the conference over to Ara Janoyan. Please go ahead.
Great, thank you. Well, on behalf of the American Lung Association, we thank all of you for joining us on our webinar today. This is a great opportunity to engage with diverse stakeholders and to discuss the Lung Association's Asthma Guidelines-Based Care Project. We'd like to take this opportunity now to introduce ourselves, for the speakers to introduce ourselves. I'm Ara Janoyan. I'm the Director of National Health Policy with the Lung Association. I support the Lung Association's policy initiatives surrounding Medicaid, Medicare, and implementation for asthma, COPD, and lung cancer. I'm also the project manager for the Lung Association's Asthma Guidelines-Based Care Coverage Project.
I'm Annie Yu, and I'm the Health Policy Research Associate, and I assist on several coverage policy projects, including the Asthma Guidelines-Based Coverage Project.
Great. And for today's discussion, we'll begin with a brief background on the development of the Asthma Care Coverage Project before we provide our findings on the first nationwide comprehensive analysis of state Medicaid coverage for guidelines-based care. Later in the webinar, we'll discuss what challenges are reflected from our data findings and the next steps that you can take to help improve the health of people with asthma and Medicaid. And here we'd like to simply provide a brief update on what's new since our Asthma Care Coverage Projects launched last year. In 2016, we researched 23 states that were then funded by the CDC National Asthma Control Program. Mississippi and Puerto Rico were later added as newly funded grantees this year as well. And this year, we have updated our findings for the 23 states as well as gathered data on the remaining 27 states, DC and Puerto Rico. And secondly, as part of our research, we confirm our data findings with state Medicaid offices. Last year, we established state Medicaid contacts for 23 states that were funded last year, while this year we have established state Medicaid contacts for all 50 states, DC and Puerto Rico. And with millions of Americans, including a significant number of children living with asthma, it is imperative to ensure access to treatments and services that will help reduce the burden of asthma and improve asthma health outcomes. Here we can see the impact that the burden of asthma has on hospitalizations, school absenteeism, and on a health system's perspective, given the prevalence of asthma in Medicaid populations. The Lung Association has long recognized the importance of adherence to best practices in reducing the burden caused by asthma. The Lung Association strongly supports and believes that care for asthma patients should be based on the recommendations in the National Asthma Education and Prevention Program Expert Panel Report, which are provided here in general. Given the burden of asthma and its prevalence in Medicaid, as previously provided, adherence to evidence-based care will help reduce the burden on individuals and their families while improving health outcomes. But despite the establishment of the NAPP guidelines, a gap remains between what is known to be best practice in improving asthma outcomes what is being covered by payers, including state Medicaid programs. Here I would like to provide a background on the Asthma Care Coverage Project. In 2014, the American Lung Association launched its Asthma Care Coverage Initiative to reduce the burden of asthma and improve the health of people with asthma through increased access to medications and health services. In 2015, with funding from the CDC National Center for Environmental Health, the Lung Association created its own Asthma Guidelines-Based Care Coverage Project and began to carefully research state Medicaid coverage and related barriers to access of asthma care treatments and services. The objectives are to increase availability of state Medicaid coverage data, to further understand the gaps or deficiencies in coverage, and to increase public health stakeholder engagement toward improved coverage of asthma care in Medicaid. And here we have the 7 categories of care and the 9 related barriers that are tracked as part of the Asthma Care Coverage Project. You'll see that we have we're tracking quick relief and control medications. For quick relief medications, we do track 4 medication types within 2 medication classes. And for controller meds, we do track 20 medication types within 9 medication classes. And for medical devices, we track for nebulizers, peak flow meters, and valve holding chambers. And the 9 related barriers are listed as such, range from age restrictions to copay and quantum limits and step therapy. The data collection process is something we'd like to share in brief here as well. The data collection process is both intense and comprehensive, and we have also provided our entire methodology on our website for you to learn more. Generally, our methodology includes the careful review of publicly available documents and fee-for-service and Medicaid managed care plans for each state, DC and Puerto Rico. Documents, pardon that, apologies for that. And include the careful review of publicly available documents in fee-for-service and Medicaid managed care plans for each state, DC and Puerto Rico. Documents do include member handbooks, provider manuals, drug lists, preferred drug list formularies, and any other relevant materials to determine coverage and barrier-related information. Additionally, as part of our methodology, we do collaborate with state Medicaid agency contacts that we have now established nationwide to help in the confirmation of our data findings. And now the next slide that you had a preview on, we'd like to provide a display of how our data are now being made available on our website with further details on coverage and barriers. Every state, DC and Puerto Rico, now have individual pages that can be selected from the drop-down menu. On this page, you will also find our glossary, methodology, and 7 maps, which represent the 7 categories that we're tracking, to give a nationwide perspective of coverage and barriers to guidelines-based asthma care. And so once you make a selection of your state to learn more about the coverage in your state, here we've provided a random example of a given state to illustrate how you may now easily view the extent of coverage for all the 7 categories of care, as well as identify which of the 9 related barriers that were tracked actually exist for the covered asthma care service. Here's a short preview of some of the medications for this given example. A Y or yes coverage, noted in the first column, denotes coverage across all state Medicaid programs. An asterisk denotes coverage varying by state Medicaid plans. And for those barriers that were not applicable or relevant to a given category of care, they were denoted as not applicable. The barriers here are a reference to those plans that actually do cover the treatment or service. So here we'd just like to give a very brief example of interpreting it. More information can be found on the website in our glossary. For example, here for albuterol sulfate, it is shown to be covered for all Medicaid enrollees in this given state. And in all the Medicaid plans that do cover albuterol sulfate, copayment exists in some but not all the plans. Alternatively, levoalbuterol is covered in some but not all the Medicaid plans in that given state. And for those plans that do cover levoalbuterol, quantity limits are found as a barrier in some but not all the plans. And once you visit our website, you'll also notice that some barrier values have an NAV, which just shows that that information was not available at the time to determine the extent of its presence in state Medicaid plans. On each page, there is a state data summary report that can also be generated, which directly corresponds to the coverage and barrier information you see on your screen for that state. More information on how to interpret the state data reports alongside our coverage and barrier values can be found in our glossary as well. And lastly, each state page also has a list of additional sources that were used for researching that state alongside our state Medicaid confirmation process. And so Annie will now provide us with some examples of the state data report summaries I just recently referred to. Annie?
So the following 3 slides will provide examples of actual state data summary reports to actually illustrate the variation in coverage and barriers. We will be using medications as an example, and as you can see from the top, we do have a legend. Green checks denote coverage for all Medicaid enrollees across the state Medicaid plans. Yellow triangles denote coverage that varies by state Medicaid plans, and red X marks denote no coverage for that item. Here we see Oklahoma, and the Oklahoma Medicaid program covers all the medications that we see here. However, as you can see on the third column, barriers still exist for some of the covered medications. Moving on, we see for Nebraska, we have the same type of medications from the previous slide. We see that all the medications here are also covered in their state Medicaid programs, but as you can see, there are barriers for every medication shown. And lastly, we have Arizona, and with Arizona, you will see variation in the extent of coverage as well as barriers to accessing these medications in the state Medicaid programs. Some medications are available for all Medicaid enrollees, as noted in the green check marks, while other medications are available only to only some Medicaid enrollees, as noted in the yellow triangles. On the next set of slides, we will provide a nationwide perspective of our findings across all 7 categories with a set of maps that can illustrate the variation in coverage and barriers across all the states, DC, and Puerto Rico. So the following information can also be found in our glossary that is available on our website. So the states in red indicate covered without barriers, and this means that we were able to determine this from each state data report by seeing all the items under a category of care that was covered without any barriers. So what we're looking for in terms of optimal coverage is a map covered in red. As you'll see in the following 7 maps, there actually is not much red, meaning there's a lot of work to do in terms of getting better coverage. Green shows that it is covered, but that there may be barriers. And all the items in the category of care should be covered, but some of them may have barriers. And yellow means some coverage. For categories of care that do have single items, which include allergy shots, home visits, and asthma self-medication, and asthma self-management education, it means that these categories would have coverage varying by state Medicaid plans. And for categories of care with multiple items, such as medications, medical devices, and allergy testing, these categories have a mixed array of coverage for these items. So some of these items may be covered across state Medicaid plans, while other items can vary by plan or are not covered at all. Purple means that there's no coverage for this category, so we actually do not want to see any purple. So as you can see in this map for quick release medication, we see a range of coverage. There is a slight majority of states that are represented in yellow, which means that these states appear to have variation in the number of medications covered and the extent of coverage for those medications across the state Medicaid plans. There are, however, 23 states that we can see in green that appear to cover all quick release medications but have some barriers. Both of these are good signs, but we still want to see coverage without barriers on the map, and we do want to see these maps turn red. So for the next category, for controller medication, the map is overwhelmingly yellow with only 8 green states. So this means that we do see all the states appearing to cover controller medications in some capacity, and while it is good to see some forms of coverage, we would like to, again, move towards coverage of all controller medication, more green, and definitely the end goal is red. Similarly, the coverage map for medical devices is also predominantly yellow with 35 states and DC and Puerto Rico indicating a mixed range of coverage and barriers. Again, we would like to see the 3 purple states that appear to have no coverage and the 35 states and DC and Puerto Rico that appear to offer some coverage all move towards more coverage and less barriers to care. For allergy testing, there's a great range of coverage. We observed 6 states in red that appear to have coverage without any barriers, which is great. While we do see 7 purple states that appear to not cover allergy testing, a majority of states do appear to have coverage but with some barriers. So for both allergy testing and allergen immunotherapy, these are categories in which we find most states in red covering the services without any barriers. We are seeing, however, that there are 14 states in Puerto Rico in green that do show coverage with some barriers. However, more than half of these states either have some or no coverage of allergen immunotherapy, so that's something we would like to see change. Here we see a stark contrast from the prior maps with the vast majority of states in purple. Of all the categories tracked, home visits and interventions is the category with the most states that appear to have no coverage in purple. However, it is important to note that 3 states do appear to cover home visits and interventions with no barriers. Additionally, quite a few states seen in yellow appear to cover home visits and interventions with varying coverage across state Medicaid plans but with barriers. And lastly, our last category is asthma self-management education, which shows a lot of variation between the states. We do see 6 states that appear to cover self-management education with no barriers, but there are 15 states that do not appear to cover self-management education at all. The majority of the remaining states offer some coverage. And now we will discuss next steps that can be taken with this available data.
Great. Thank you, Annie. And so For the data on the state Medicaid coverage of asthma guidelines-based care is now available, and the state Medicaid contacts have also been identified by the Lung Association. So this is where the opportunity for state stakeholders comes in. While these ideas go a little beyond the scope of this project, we wanted to leave you with some suggestions on what some next steps might look like. So the objective now is to foster a dialogue and to continue to foster a dialogue and to increase collaboration between diverse stakeholders, including state asthma and Medicaid programs, in order to educate decision makers on the significance of asthma guidelines-based care to improve patient outcomes. The first focus, as you see here, is stakeholder mobilization and partnership building. Here you may build on existing asthma coalitions in your state and further expand your outreach by including community groups and organizations that represent key stakeholders, which may include physicians, payers, hospitals, school nurses, etc. For example, identify your state asthma coalitions, your state lung association, and also determine if your state has a Medicaid coalition focusing on improving the health of Medicaid populations. The second focus, as you see here, might be to have the stakeholder groups mobilize and determine coverage priorities. By having a diverse set of stakeholders in your coalition, you can assess the urgent needs that must be met in your communities and state to improve the health of those who live with asthma. For example, your coalition might determine that while coverage is lacking in all 7 areas, there may be an urgent need for increased self-management education or perhaps increased access to medical devices. At this time, we'd like to take an opportunity to also mention that the additional resources that are available to perhaps help assess the extent of self-management education, for example, in select states, is our recent 10-state analysis of providers, services, and settings for asthma self-management education, which the Lung Association has created alongside our colleagues at the George Washington University Milken School of Public Health. This actually currently is available on our website, which you'll see later in the webinar. And this is just one of the many examples of analyses that can help supplement your efforts with partners and stakeholders to assess the nature and extent of coverage and barriers in your state for a given area of treatment. The third focus, as you see here, is to educate the decision makers on the significance of increased access to asthma guidelines-based care to help reduce the burden of asthma and improve health outcomes. For example, your ever-growing coalition might create sign-on letters to identify the needs and to help explain the problems with the lack of access to guidelines-based care. Letters with an array of logos always get attention. And with that, I'd like to pass it on to the operator to help with the instructions on inserting Q&A or questions that you may have.
If you would like to ask a question today, you may enter it in the Q&A box that's located on the right-hand side of your screen.
Okay, the first question is, on the controller medication map, does the yellow coding mean that some health plans don't cover any controller medications at all?
Great, that's a great question. For yellow, for controller medications, because there are multiple medications in that category, the colors on the map were generated by the state data report summaries, which are available online and that Annie had discussed earlier in the webinar. And so, for example, you could pick any yellow state, and how it's interpreted then is that across all the 20 medications that are covered under controller medications, not all of them are covered at the very least. So at the very least, you may have at least one medication that is not covered, or at least one medication that varies by plan and coverage across the state Medicaid plan. And therefore, as a category grouped with all those medications under controller meds, not all of them are covered to denote a green, or not all of them are covered without barriers to denote a red. So there's at least one out of the 20 that is not covered, or the coverage varies by plan.
We got another question about whether or not we identify any specific plan information. And the answer is no. We do not specifically identify what a managed care plan does. What we focus on is how overall Medicaid plans respond. Ultimately, it can be Medicaid's responsibility to set the policy levels and the acceptable coverage for all MCOs in its state, and that's what these data are focused on. Oh, would you please restate, the question is, would you please restate when you collected the Medicaid data?
Great. And the Medicaid data was covered between July and June of 2017. So we have collected data, as we showed in our initial map. At the start, we had collected data on 23 states last year, and this year we had updated that information as well as gathered the remaining 27 states, DC and Puerto Rico.
And is it the case that if you find out that a state has updated its coverage for good or for bad, that you will update the database? Ara? If a plan...
Correct, yes. You can, there is a asthma care coverage or an email address that we'll provide at the end, where at any time, if any individual may come across more information, feel free to forward along. And as part of our confirmation process, we do confirm with state Medicaid, so it is updated on a continual basis.
We got a question about what are some of the barriers to coverage. And so we will pull up that slide. There are a list of 9 of them that you can see on your screen. Do you want to just address briefly why they can be barriers to coverage?
Sure. For example, for age limits and age restrictions, a lot of these, simply because the plan may cover it, the next step is obviously what are the particular criteria or circumstances or conditions that must be met in order to get access to that treatment or service. So age limits are when treatment or service is covered under a certain age, so maybe covered for those under 12 or et cetera, and age restrictions are for services that are covered above a certain age. And quantity limits, of course, could be a barrier, especially since you may have a need for more medications than is required. Step therapy is a barrier, of course, under the circumstances where they require you to go through multiple medications before you move forward with what the patient and provider have believed is the best sort of course of action for that. So those are the simple examples of that.
Good, and it looks like at the very bottom of our question list that there is a follow-up on that. Can you comment on which barriers to care were most common? Which ones did you see most often as you all reviewed the data?
Sure, that's a great question. And the barriers are, across all the states in the country, it'll vary from state to state. And so if I could just pull up that here, the random sort of state example that I've used, and every state has their own unique individual state page with the data and barriers. And so some states may have, as you see here in this given state, maybe co-payments and quantity limits may seem to be the most prevalent, at least for the medications previewed here. And if you scroll further down on the side for medical devices, self-management education, or allergy testing, maybe age restrictions become more prevalent, or prior authorization. So, and that's sort of the unique part of the project, is that you get to learn more about, the sort of, you want to aim for consistent coverage and lack of barriers, coverage without barriers. And so it's a great opportunity to see how states are doing in coverage, and then after that is the second follow-up with regards to the barriers and what steps could be taken to help reduce those, reduce or eliminate those barriers for that matter.
How about? Okay, we got another question. Is there any concern for Medicare, actually Medicaid expansion states if there are changes with the new health care bill? And yes, I mean, the answer is that there are always concerns with how changes by Congress will impact state coverage. And so much is up in the air right now that I think that's a very difficult question to answer at this time. So I think we're going to have to say stay tuned on that one. Okay, we got another question. Any reason why information on the availability of biologics was not included or covered in this discussion?
Well, for the particular biologic referenced here, that's actually one of the medications under control or medications that we do track. And so, we do track that along with the other 19 for the control of medications across all plans, Medicaid managed care plans and fee-for-service in all states.
Okay, we are looking for our next question, and there we go. So regarding self-management education, did you get any information from states about the setting in which SME would be reimbursed or the credentials of the provider?
That's a great question as well, and in our analysis, we looked through member handbooks and provider manuals and any other relevant documentation to help determine whether self-management education is covered. And as noted earlier in our webinar, one sort of additional resource we can reference to, which is currently posted on our site as well, the asthma self-management education analysis, the 10-state analysis done based on our findings from last year. But of course, everything is updated at this point, and there's a thorough analysis that goes and breaks it down by provider and service and setting type. And so that most certainly has a lot of information on clinical and non-clinical providers as well.
Okay, another question. Is there any way to find out why a state is not covered under the CDC management program grants? Texas had an asthma program through CDC, but the funding was cut according to the Texas Department of Health Services or Human Services. We say we don't know. And the answer, I will answer this. This is Erica Sword. Congress had a number of challenges with funding for the overall CDC program. So, and as budget cuts have occurred over the last number of years, CDC's had to make some very difficult choices, and we know that ultimately the number of funded states did shrink as a result of some of the funding that Congress did not provide. So encourage you to reach out to the CDC National Asthma Control Program staff for further details on that. But, you know, the Lung Association would certainly like to see one day that all 50 states plus DC and Puerto Rico receive funding to make it a truly national asthma control program.
Great.
Okay, next question.
Great, and I know we do see a couple of questions here with regards to what, with regards to certain categories, if it be medications or home visits or self-management education, certain individuals from certain states would like to wonder, you know, the extent of coverage in that state, given their experience of the programs that currently exist in their state. And as Eric and I mentioned earlier, that the information is continually being updated, and so if there is any sort of specific state that you're from and you see a particular thing that may be covered but should not be covered, or it appears not to be covered but in fact it is, that's the information that we of course welcome, and the email that we'll provide at the end is the place where you could send it forward along to us.
And Ara, I think it's another good point to highlight that if it's not in writing, it doesn't exist. One of the things that we know is that sometimes there can be confusion within the Medicaid program and within payers. And so ultimately the Lung Association standard is that it does have to be in writing for us to recognize that coverage exists, and from there. So, okay, next question. Do you have examples of states that have implemented programs or other initiatives that have demonstrated a change in coverage that reached the Lung Association's benchmark goals? And I would say that I think that we are in the very early stages of this, but there are some really exciting opportunities that are going on with CDC fostering relationships between state asthma programs and state Medicaid programs. And one of the goals of this very project is just to raise awareness of how critical it is to have comprehensive and consistent coverage for guidelines-based care. And that's really what our data are going about doing. So, Ara, do you have anything to add to that?
No.
Okay. I think we have answered that question. And oh goodness, a coding question. For folks asking coding questions, what I would suggest that you do is to follow up with the website. And maybe we can go to the last slide right now, where we have the email address for you all to be able to submit questions, and that anything technical on coding and other things like that be submitted via email so that we can thoughtfully respond to that.
And just to follow up on that is that in our, once you visit the lung.org asthma care coverage website, you'll see our methodology document, which provides information on CPT codes that have also allowed us to determine coverage on certain categories. And so, but as Erica mentioned, feel free to forward any additional information along to us at that email address that you see here.
Okay. Any last questions?
And once again, to enter a question, you may do so by entering it in the Q&A box on the right-hand side of your screen.
Okay. Wow.
All right. Well, thank you again for joining, and we look forward to working with everybody. Feel free to pass along any additional information, and thank you.
Thank you. This does conclude your teleconference for today. We appreciate your participation. You may disconnect at any time.